and I honestly, and I'm going to tell you, because I've heard this in an AAO, American Association of Orthodontists. I heard this once in the restroom, and it stuck with me. And I was like a resident. And they said, never teach the general and pediatric dentists how to properly do phase one. Or if we do phase one, we should just not do the lower, because if we do the lower, then we know they might not need phase two, or it'll be too easy and they'll never send the patient back to us. I don't know who it was, but I heard that and I'm like, challenge accepted. All right, well, what if I start doing things really well in phase one? And yeah, okay, you guys might take this as an easy Invisalign Lite case or an easy Invisalign Go case, but now, hey, I know I'm doing the right thing. These parents are going to send me friends and families and other siblings, and that's great. That's the right thing to do. That's what orthodontics is about. So I hope that's a great take-home message for everybody. That's why I found you, because I was like, this guy expands the lower. This is great. They say it can't be done, and it should be done.
All right, welcome everyone. Very excited to have you all here tonight. I'm based in New York City, and Dr. Wilson, our special guest tonight, is all the way from Hawaii. Aloha, is that where we?
Aloha, yeah.
Yeah, my dear brother, Dr. Simon Wong, is based
Hello.
in Melbourne, Australia. So good morning to you. And another guest, Mr. Enrico Di Giovanni, welcome from Melbourne, Australia as well. And dozens of guests
Hello.
from the world, from Dr. Silver in Ottawa, Miami, Angelica, some guests in Australia, Andres, Dr. Tamayo, and also from Pakistan. Welcome, welcome. So let's have a quick introduction, if I may. Oops, there we go. My emails are, sorry about that. We'll edit that out.
I've seen worse.
So an introduction to postural orthodontics tonight. It's a bit of a masterclass, a discussion on an orthodontist's perspective on early intervention. Tips and tricks on finishing cases and the power of posture. Dr. Amanda Wilson, a very special guest, and my brother, Dr. Simon Wong. Oh, let me just mute out our dear here. Sorry, Enrico. Got to meet you out there. I'm busy in the lab. All right, so now it is also at the very end, we're going to have a little preview. We're very excited about this. This is the first time Simon is presenting this 2-day intensive on postural orthodontics in very close to New York City, 30-minute drive. It's near Newark Airport, Doubletree by Hilton, and where in person Dr. Amanda Wilson will be there. My brother will be there. Enrico as well. Dr. Kevin Boyd. And for those of you, meet also Dr. Narinder Singh from Sydney. He won't be flying up, but he'll be joining us via Zoom. Stay till the end because we have a very special offer. And but without further to do, let's have a look here. My brother, let's introduce him. My brother, Dr. Simon Wong. Firstly, my name is Kian Wong. I'm the kind of bit of a host, and I've been organizing these events for him the last few years. But I'm very happy to introduce my brother, Dr. Simon Wong, the founder of Postural Orthodontics and a leading expert in facial growth guidance and early intervention. He's held the position of visiting professor, co-director of the Orthotropics module at the University of Valencia, Department of Orthodontics, and is a fellow of the International Academy of Dental Facial Aesthetics. Past 15, 20 years as the principal of the Clinic Natural Smile Center, based in Melbourne, Australia. He's been focused on the correction of early childhood craniofacial development issues, a devoted practitioner for the early correction of malocclusion. He's published and is a published author with journal and textbook articles on sleep disordered breathing, with his most recent article, Jaw Epidemic: Recognition, Origins, Cures, and Prevention. His current clinical research at the Orthodontic Department of the University of Alberta, and most recently at Texas A&M, the supervision of Dr. Peter Bajang, will hopefully provide the pathway for the future of orthodontics to be focused on cures and prevention for all oral facial development issues for our children. And our guest speaker, Dr. Amanda Wilson, orthodontist and founder of Straightsmile Solutions. Dr. Amanda Wilson is an orthodontist with 23 years of experience in the industry. After graduation at UCSF and UConn, she spent 10 years in private practice. And then in 2013, she pivoted sharply to research, product development, teaching, and consulting with the emphasis on aligners, IDB, airway, SDB, and growth and development appliances. She's now is the CEO of Straightsmile Solution, an orthodontic coaching consulting company for general and pediatric dentists and dental labs. And she splits her time between Hawaii and California. Has two wonderful kids aged 15 and 18. And she's also a volunteer and troop leader for Girl Scouts USA and is a stroke and turn official for USA Swimming. Welcome, Dr. Wilson and Simon. Welcome, welcome, and welcome
Thank you.
everyone. All right, I'm
Thank
going
you.
to pass it on to Simon to start proceedings. Simon's going to do a short little presentation, and then we're going to have a more of a podcast interaction with Dr. Amanda Wilson very shortly.
Okay, thank you. So we're very honored today to have Amanda join us in our informal conversations about early intervention orthodontics. Most of you are here actually because you have been fortunate enough to have had Amanda guide you in your journey in orthodontics. But I thought it would be good if you just got a sense of who I am and my own journey. So I'll share a little bit about the last 15 years of my practice and specifically in the orthodontic component. We switched journey. This is my probably 33rd year in practice. And my focus was never on children. And it's only the last 15 years that I trained in orthodontics and specifically started to focus on early intervention. So I think it'll be good if you just got a sense of my journey and my practice life in orthodontics. All right, I thought that might be a good place to stop. We are on a time line, but part of the research that I'm doing with a couple of the universities in North America at the moment, we are studying consecutively treated cases, and you're welcome to log on to our website and have a look at the treatment that we are currently investigating that was provided by my practice. So today we're going to spend a little bit of time and just give you an idea of my journey in early orthodontics, maybe some clues as to how my specific brand of postural orthodontics is different from other functional approaches, give you some ideas on some of the things that we do, such as mandibular arch expansion and how that's possible. And obviously, we're going to spend a little bit of time with Amanda and get some insights in how she has been able to help many of you in your journey in orthodontics, and to give us some clues as to how she will help us into the program in the future in September, which is something that we're very excited to be able to offer September the 27th and 28th of this year, New Jersey in the United States of America, where already many of you have signed up, and I look forward to meeting you in person. So I never was interested in ortho. I trained in the 80s and was very much driven about restorative dentistry and rehabilitation dentistry. And it wasn't really until about 15 years into my general practice where I started to encounter issues of temporal mandibular disorder and significant issues in regards to sleep apnea. And it was only at that time that my mentor at the time, when I questioned him as to how we might do more than just manage these chronic illnesses, he said, well, you've got to learn ortho. You've got to help children by preventing them from developing these issues. I was lucky to come across John Mew, who has really steered my view of growth and development. And I came across his book, The Cause and Cure of Malocclusion, and it triggered an awareness and a passion in the management of some of the chronic issues that we're dealing with in adults, but by attacking the root causes in childhood. So one of the things that I hope, irrespective of whether you spend time with myself or Amanda, is at least be open to looking at what we call the etiology of malocclusion. And I don't believe there's a better author than John Mew in helping us understand the biology behind how malocclusion develops. Australia is an island, and although it is very much a good environment for learning, I had to travel. I had to travel to the United Kingdom, I had to travel to Europe, I had to travel to the United States to learn orthodontics, to learn early intervention. I was very fortunate in my journey to have encountered my lab technician partner, Enrico, who has been instrumental in helping me develop the systems and the protocols and the appliances that I'm now able to share with you and the rest of the world. I've been fortunate to have wonderful teachers, John Mew, Mike Mew, Bill Hang, who have guided me and paved the way through their own experiences and their own trials and tribulations into my now being able to share my experiences and to pass on my knowledge. One of the problems that we faced was helping people, helping dentists, helping orthodontists, helping parents, and helping children understand how to tackle the development of malocclusion, how to manage the side effects, and how to gain a sense of stability once treatment has been carried out. And I understood that posture, the resting position that we hold in our body, has a significant influence in how our bodies develop. In our early years, we are very much moldable, plastic, and soft. We grow from 2 cells to the size of a loaf of bread to, in some cases, over 6 foot in height. We do this in a very short timeline. And that enormous growth potential also carries with it some disadvantages. We're very subject to the environmental forces around us, in particular gravity. And we all were raised with the good understanding that core stability, tight abdominal muscles, played a very important role in holding a straight spine and allowing a child to develop straight and true. And what we realized when I was investigating the root causes of early childhood malocclusion was that this fundamental understanding of biology and physiology is no different whether it's the spine or the jaws. And so I started to focus my attention on developing understanding of how oral posture, the rest position that you hold your jaw, what role does that have in growth and development of the jaw and the eruption and the alignment of the teeth? So I created a simple instruction book, kind of targeted at the 5th grade level. And we focused our understanding on body posture and how we utilize certain aspects of upbringing and childhood development. And in the research that I did on posture, I came to the awareness that there are fundamental components to posture that create good oral jaw development. We know that with strong posture, when we rest with our mouth fully closed, we have better health and we have straighter growth. We know that if we breathe through our nose at rest, we increase the parasympathetic drive. We know if we use the structures within our mouth wisely and efficiently and effectively, we develop much more powerful structures. Conversely, if we transition into good digestive process, again driving parasympathetic tone, we coordinate the interplay between function and posture. I put this into simple terms that the children that we're targeting can understand. And it was not surprising for many of us to realize that these fundamental principles have already been in our awareness for thousands of years. We have historically called them manners. My grandmother raised us in a very specific manner. She made a very strong point that our presentation to the world, how we talked, how we walked, how we ate, how we addressed people, our poise was important, was significant. She used to use the term, you have to present well to the world to make your family proud. I suspect the science behind this is exactly the same science that we use today in developing straight teeth using orthodontic approaches that are functionally based and posturally based. I developed simple exercises that actually were founded by 5,000 years of Chinese culture in raising children. I came across orthodontist in San Francisco, Sandra Khan, who suggested that we put this into a book, an instruction manual, a means of passing this information on. And so we developed GOPEX, Good Oral Posture Exercises. I took this around the world. About 8 years ago, we started touring Europe, sharing predominantly with pediatric dentists, some orthodontists. We were able to bring this in 2019, just before the pandemic, to the University of Mexico. And I was privileged to be able to speak to 1,000 pediatric dentists in Mexico City. We were able to share that what I do is different to many other forms of early intervention. We use appliances that are removable, very similar to 100-year-old appliances that have been around, but using modern technology to ensure stable, playful instruments for the children. We have systems that allow us to develop space in young children where historically we've had to accept the compromise of extractions. We've been able to develop arch forms in the maxilla, but interestingly, we've also been able to develop enormous changes in the mandibular arch. Now, when I trained, I was taught once the lower permanent canines come through, no further arch form development is possible in the mandible. Mandibles cannot be expanded. It's written in stone. Yet I was seeing changes that were difficult to explain when you looked at textbooks and when you looked at research. And it was only until I learned about growth, childhood growth, the skeletal growth of the maxilla and the mandible and the craniofacial development, that I realized the proportions of our jaws are completely reversed in our early childhood. We all know dental alveolar bone can be easily developed. Orthodontics is based on that understanding. When we investigate the volume of dental alveolar bone in, say, a 7-year-old, when we look at this pantograph, this OPG, with the eye of not where are the teeth, but how much of the jaw is taken up by the teeth, that we realize it's all Play-Doh at this age. We don't have to accept that if we're crowded at the front, we have to serial extract. We don't have to accept this in a 7-year-old, in an 8-year-old. We know we've been taught this. We also know that we're taught this because all our professors work with teenagers. Their focus is on 13-year-olds. And when you enter the door as a teenager with your canines, permanent canines in place, your premolars through, your 12-year-old molars through, your 13-year-old canines through, your bones are rock hard. Puberty does that to us. And we have to accept that we cannot develop big changes. We are not alone in making this up. In fact, we know at the University of Michigan, the last 4 decades has been focused specifically on mandibular arch development. How, if it's done in the early or even the late mixed dentition, what impact does this have? And we know not only can we develop maxillary arch form, but we can eliminate many of the transverse and AP discrepancies. We know that if we combined attention with the maxilla and the mandible, we can make significant improvements in disimpacting canines, in developing room without the need for extraction of premolars, and in fact, as quoted, enlarging the nasal airway. One of the things that I had been worried about on my own learning journey was that many of the early interventionists were teaching material that was lacking in evidence basis. That was, at best, fringe orthodontics. And my hope in developing this system is to find a way of staying well within our existing standard of care and utilizing evidence-based protocols, and when not researching my own work, to provide the evidence needed for it to be safe and predictable practice. I was very fortunate during our teaching in Spain to have the University of Valencia start preliminary investigations of my cohort of children. We evaluated 33 class 2 division 1 patients, and we compared them to the twin block patients that were being treated at the university. And interestingly, we found when using my BioBlock orthotropic system that we were able to reduce A and B by 3.5 degrees. And in comparison with twin block, that was only at the level of 1.4 degrees. Now, we know, and we have been given definitive research to show functional appliances can only move teeth within their dental alveolar bone. There is no capacity consistently for functional appliances to have a skeletal effect. The exception to that rule to date is the Frankel appliance, that's been shown to work quite well in marginally improving AP discrepancies on a skeletal basis. Now, if we look at twin block, if we were only able to reduce A and B by 1.4 degrees, we will almost universally find that a class 2 will not be corrected. But I challenge you to consider, if I could reduce your class 2 by 3.5 degrees, would you consider that a skeletal change? In addition, what we found is much of the class 2 that progresses in our children is down to a vertical increase, particularly during treatment. There's an old saying of chasing your tail when you are trying to close the overjet. Right? You seem to close it, you put the elastics on, you put the mechanics on, it's looking good, and then they disappear for 6 weeks, come back, and it's worse than ever. And we tend to find that when vertical increases, when we put braces on molar teeth, when children hang their mouth open, iatrogenic vertical increase is a common phenomenon. Yet, when we investigate block orthotropics, which is a posturally driven early intervention process, we were able to show a closure of almost 2 degrees in vertical. Now we know this is not normal. Vertical increases in normal growth. In comparison, we are 4 times the magnitude of improvement compared to conventional treatment, which is standard of care for functional appliances. That raised the interest of the University of Alberta and the University of Texas A&M. And I've been very fortunate to have some of my cohorts be investigated. We now are at the point where there's over 130 consecutively treated cases, and we've been systematically reviewing these in follow-ups now approaching 15 years. We have been able to come through with results that have been classified as significant. The last master's thesis summary that was done at the end of 2022. Bioblock therapy produces significant improvements of AP, maxillomandibular skeletal relationships, produce significant molar correction and reductions of overjet, changes mandibular growth in a more horizontal direction, does not have negative effects on mandibular divergence, producing slightly greater true forward rotation than expected. At the moment, we are putting together a paper under the request of Angle Orthodontics to share the findings from the University of Alberta. And hopefully this will have an impact on how we approach early intervention into the future. All right, Kian?
Shall we bring on Amanda before we, well...
Yeah, for sure.
Hello.
Hello. Welcome.
Hello.
Thank you for that presentation. It was great to see your cases.
Thank you. One of the things that we're really excited to be able to have is this relationship that we have with you at the moment. Amanda, you've been in orthodontic education for over a decade now.
Mm-hmm.
And seeing your impact on general dentists and their training has been very heartening. One of the things that I found when I was learning was a very closed old boys club as far as orthodontics is concerned. And it was very much elitist and keep the general dental rabble at bay. To see you take on, I suppose, the responsibility of helping a greater number of children access orthodontic care by coaching general dentists who are able to treat a broader range of milder.
Oops, has Simon frozen?
I think he froze. Okay, I
Yeah,
wasn't sure if it was me.
getting,
I was like, is it me?
I think he'll be back, hopefully.
He'll be back.
Yes. So let's.
Well, I'll respond to that, and when he comes back, I'll shush. But yeah, I completely agree with him. When I went into residency, it was definitely a lot more males and females. I was the only female in my residency class, which was small, but it was definitely different, you know, than it is now. And there wasn't a lot of shades of color. You know, it was very much one color, monochromatic. And it was, yeah, it was really different 20 years ago than it is now. Anyways, he's back, so I'm gonna let him finish his thought.
Must have frozen. Well, one of the things that I wanted to bring up today was maybe some of your insights from your experiences, both in teaching and in practice. Some of the questions that I know the inexperienced orthodontist, as well as the learning general dentist, always raises. We know, for example, there's a big debate that has raged in orthodontics about extraction of bicuspids. We know that it has been a system that has been very predictable in the hands of experienced orthodontists, taking 2 bicuspids or even 4 bicuspids. It's a very good way of managing AP discrepancies, reducing or hiding class 2 or class 3, respecting the neutral zone for stability, and kind of keeping within the whatever the arch form presents. If we keep within that arch form, we're less likely to have relapse issues. But in the last, I'd say 15 years, there has been a swing away from pulling every premolar out. We've been using light wires, we've been using broad art forms, we've been using frictionless brackets. Now, there is thought that says all that will do is tip teeth and you'll never coordinate arches and it'll always be unretentive. What's the reality?
Oh goodness, we could talk about all this for hours. But like I said, when I went to residency, things have changed so much in the last 20 years. If I had to guess, maybe 20 to 30% of our cases were extraction cases. So I was definitely trained on extraction therapy. I mean, yeah, it works. You make straight teeth, but afterwards, I mean, sometimes, you know, we do these treatment plans, and the preceptors or the faculty preceptors would say, yeah, you must take out teeth hair. And in my gut, I was like, do I have to do that? But I didn't have a choice, right? And you know, after I did it, it just never felt right. And I kept asking. We did almost no phase 1 cases in residency. I mean, and if it was just cosmetic. It was somebody that was in acting and they just wanted straight teeth, and maybe we didn't expand her, but usually it was like extract C's and straighten the front teeth, and then literally you're just moving the problem further back, you know? So, but yeah, I mean, extractions were a thing, and a lot of people have extracted premolars. I definitely think there needs to be more studies, longitudinal studies, going from the kiddos now, that maybe where we can measure the airway now, you know, using the techniques that we have now with CBCTs and follow them around long 50, 60, 70 years to see how the airway changes. I think that's really important. But in terms of what you were talking about, swinging from extractions to just pushing everything out and forward, yeah, I see a lot of that too. I see it in my daughter's friends. I mean, it's funny actually. A lot of people are still getting teeth out here in Hawaii. It's actually surprising. But I see a lot of my daughter's friends just so full, like they're literally look like they can't get their lips over their front teeth. They're Bucky Beavers, you know, and they fit everything in and it's straight. But you know, I'm wondering what's happening at night with these kids. You know, are they even able to close their lips over their teeth? And what is the long-term periodontal consequences of just blasting everything out and forward? And what is the long-term airway consequences of this? So really, I don't know. I mean, I really didn't answer your question. I just said we're going to need time to explore this. And I don't know that one is right and the other one's not. But I really think the happy medium and the right answer is what you're doing, which is catching these kids little, fixing their posture, making the space while they're still actively growing and having the teeth come in straight to begin with. And then you usually don't need that much retention. And sometimes you don't even need phase two. So I really think that's the only right answer that I can give.
Yeah, I think we, as students, have to have a simple approach. We have to follow a recipe because there's just so much, and it's so dangerous for us to ad lib early on. But you know, one of the things that sometimes happens is you do what you're told, and then you realize, for example, when you're treating your own kids, that hey, maybe there's a different approach.
Definitely.
Your daughter never had the extractions that were prescribed.
Right. And everyone told us she needed them. You know, every major orthodontist I consulted with on a difficult case said, yeah, take out 4 teeth. And we refused, you know, it wasn't going to happen.
The proponents of extraction have validity, right? Because as you said, you can't walk around Bucky Beaver where you can't even close your lips together.
Right.
But if extractions are done with consideration, that's different to extractions being done because that's the recipe.
Correct. And there are some adults, maybe more in Asian populations, where the jaws are just so far back and just so tiny. And if they can't get the jaw surgery, you know, maybe it's not available in their country or whatever, or it's just not possible. I mean, sometimes we've had to take out teeth, you know, I've definitely seen that happen. There's just no other option. So there's only so much IPR you can do. And I'm all about that in an adult, but I mean, you're talking 5 millimeters max per arch. And sometimes if you can't scoot them back, you know, the ramus is there, the tuberosity is there. I mean, you can't go out because of thin tissue periobiotype. You can't go forward because of thin lips. What are you going to do? You know?
Yeah. And I think the fallacy to this dichotomy of being black or white is that the learning dentist really needs guidance, it needs supervision, needs mentorship. And that's the nice thing about your program. You are able to help with making appropriate decisions and modifying the recipe. And so that really makes me happy that there are people like yourself who are there for those general dentists who want to expand their scope of practice.
Thank you.
When we are faced with these concepts that, if we extract, then we're guaranteed to have sleep apnea or TMD issues. We know that isn't always true. Certainly the studies don't show that. And we know that it varies depending on whether you're a horizontal grower or a vertical grower. And these are things that the young student in orthodontics cannot grasp. What's your approach in screening through when is it appropriate to not extract, when is it appropriate to consider surgery, when is it appropriate to look at managing things earlier so we don't have to deal with these problems?
I mean, ultimately, managing things early is always my first choice. But I mean, we always have to remember, and if there's anything, a couple key points I want everyone on this webinar today to take home. I like to always remind doctors, and most pediatric dentists are aware of this, that each child out there is unique, and each child has 3 ages. And I know that this child in your chair might be 8 years, 2 months, and that is their chronological age. But their skeletal age, you might have girls that are that age that are almost done growing. Their peak pubertal is already happening, at that age. And there's boys that aren't going to grow to their 15. So their skeletal age is different, And you also have a dental age where an 8-year-old might have 2 permanent teeth and an 8-year-old might have all their teeth in. So you can't just go, especially if you're thinking about offering orthodontics in your practice, or whether you don't want to offer it and you want to just be a better referrer to the orthodontist down the street. Remember, can't go by age. Age is just a number. Every child must be customized. And some kids, you might have to start things at age 2, 3, 4. I'm not saying it has to be an appliance. Could just be reminding them, going to ENT or getting, posture taken care of. A lot of things can be caught a lot earlier, and it can prevent bigger problems from happening that will later snowball into bad face growth, that maybe will snowball into needing either jaw surgery or needing teeth out. And the more we can educate all primary care dentists to see things, get that crystal ball out and to see things at age 2 or 3. I like to say that there's great party tricks out there where you can give me any 2-year-old and I can tell you, are they going to need braces and when they're going to need it? And I mean, so much you can see in a 2-year-old already. And I really wish, at least in the US, we always say 7-up screening. I wish it would be 2-and-up screening, because I can see everything at age 2, and not just in the chair. You have to observe the child in their natural habitat, which is, I always liked before, I'd observe the child in the waiting room. I'd be at the front desk looking around, and I'm looking at this child that I know I'm going to have an exam on, shortly, but I'm looking at them reading or playing with their phone or playing with their electronics, doing their homework, and I'm observing their mouth. If they're eating, I'm watching them eat. And there's so much you can tell just by observing a child. So take the time, to observe the child and really see what's going on and catch everything earlier.
It's very interesting that you bring that up, because one of the key points of what I'm trying to convey is the ability to read the face and to read how the children are using their mouth. There's a concept that I teach called rest oral posture. Right? Where are the lips at rest? Where are the teeth at rest? Where is the tongue at rest? What type of breathing is being done at rest? And to differentiate that between when we're in function, when running full pelt, what should we be doing with our mouth? What should we be doing with our nose? When we're resting, sitting in the back of the car, being driven to lesson, how should we be resting? In your waiting room, when they're watching TV, what's going on with their face? What's going on with their mouth? The etiology of malocclusion may be very closely tied with the resting posture. It may be very closely tied with whether we're nasally breathing at night when we sleep and whether our mouth is closed, so that the two structures can interlock and grow at the same pace in tandem. When we have children today who are allowed to talk while there's food in their mouth, don't chew their food but have to wash it down with their sodas, who hang their mouth open when they're watching television, who look like they're melting in the sun in an air-conditioned room. Right? Their fight against gravity is already lost. And that early awareness is something that is actually the responsibility of the general dentist, because the orthodontist won't see the child until 8.
And it's almost too late by then. Yeah.
Whereas the general dentist has that opportunity. And you know, those points that you bring up, perhaps I'll spend a little bit of extra time in September going through. When we are looking at intervention in that kind of early mixed dentition period, we tend to find that a lot of the attention is driven on maxillary expansion.
Mm-hmm.
And the biggest problem that I've encountered in following up in phase 2 is that we've got a huge discoordination of arches.
Yeah.
One of the things that I've been able to develop is a protocol and a system that's predictably able to develop the lower arch. If I can offer lower arch development that matches the fairly large upper arch expansion that's possible, how does that make things better, easier, nicer in the phase 2?
Yeah, and I realized that too, that whenever I only did upper arch expansion and didn't upright the curve of Wilson on, great name, curve of Wilson on the lower, that I never quite expanded wide enough. And there was never space fully for the threes to come down, you know? And then we were always chasing space. But then I noticed when I started uprighting the lower and simultaneously, maybe over even expanding, you know, a little bit more than people think, because you're always going to have a little relapse. Sometimes the cases would never need phase 2. You know, that's like crazy. I mean, you can't make that promise to anyone, but you know, sometimes you just have to give a new retainer for phase 2, and that's a blessing if you can do that. So the more, and I honestly, and I'm going to tell you, because I've heard this in an AAO, American Association of Orthodontics. I heard this once in the restroom, and it stuck with me. And I was like a resident. And they said, never teach the general and pediatric dentists how to properly do phase 1. Or if we do phase 1, we should just not do the lower, because if we do the lower, then we know they might not need phase 2, or it'll be too easy and they'll never send the patient back to us. And that resonated with me. I don't know who it was, you know, but I heard that and I'm like, challenge accepted. All right, well, what if I start doing things really well in phase 1? And yeah, okay, you guys might take this as an easy Invisalign Lite case or an easy Invisalign Go case. But now, you know, hey, I know I'm doing the right thing. These parents are going to send me friends and families and other siblings. And, you know, that's great. You know, that's the right thing to do. That's what orthodontics is about. So I hope that's a great take home message for everybody. But I agree. That's why I found you, because I was like, this guy expands the lower. This is great. They say it can't be done and it should be done.
Oh, that's we're definitely learning from the same book and not the same page.
Yeah.
All right. So this is a good time to, before there's about half a dozen questions, we'll get to every single question. But I want to take this moment to share a bit about our 2-day event, if that's okay. There is a 2-day intensive where featuring Dr. Amanda Wilson, obviously. Oops. Let's go slide down to the relevant bits. Where is it? Firstly, it's at the Doubletree Hilton by Newark Airport, New Jersey. About 30-minute drive to Manhattan if you want to find an excuse to visit Manhattan on the weekend as well. It's a 2 days, starts on Friday, you know, usually 8:30 a.m. to 5:30 or so. Both days, Friday, Saturday, September 27th, 28th. You can check out the website, straightteethnaturally.com/conference. Featuring 80% of it, I would say, is my brother presenting the core training of postural orthodontics. And we do have, obviously, Dr. Amanda Wilson presenting in person. Dr. Kevin Boyd actually will be in person presenting as well. I think I saw him. Big shout out to him tonight, if you're still there. Enrico will be there as well. The founder of 8 Point Dental Lab has worked with Simon for 15, 20 years, developing and perfecting what we affectionately call the Wong widgets, the appliances for upper lower expansion and so on. And Professor Narinder Singh, one of the top ENT surgeons in Australia, will be joining via live stream. Some words of nice words from Dr. Mike New, who's been very supportive, who's been referring all inquiries about orthotropics to us. So it was a wonderful endorsement. And importantly, when you join the 2-day event, you're going to be joining a community of 330 plus folks who are very mission-driven, airway focused, and really passionate about helping young children, obviously, right? So this is a private Facebook group, and currently we still are in early bird. The prices will go up end of the month, so there's a bit of time to obviously check your calendars and so on. There's a standard ticket in person, 1,700. It's about 30% off, whatever it is. VIP ticket is at the moment only about 2,200, and there's a live stream ticket. If you can't make it and fly over in September, you can join from home anywhere around the world for $12.97. With the VIP ticket, you do get to have a dinner reception with all the guest speakers. Unfortunately, the table with Simon is full, but there's still seats with Amanda and Kevin Boyd, etc. So do check in on and let us know who you'd like to sit with for the Friday evening. Now, another VIP bonus is the recordings of not only that 2-day event, but you get instant access to the recordings of last year's event in Sydney. Same core training, had different guest speakers, but you get the training, the video on demand, you get the hundreds of slides, the practice templates. There's a lot of things that have been included in the resources section, so you can literally up and running after going through the core training. Another bonus from Amanda Wilson, Dr. Wilson, if you join the VIP, is a free one-on-one case review that she normally charges. If you go to her website, Straightsmile Solutions, she charges about $450 for that case review. So it's included for the first 20. So there's about 10 spots left for the VIP tickets, so to speak, that include this free bonus. And once again, there's that live stream recordings, I beg your pardon, if you either buy the VIP ticket or the live stream. If you purchase the live stream ticket, you can get started straight away with the core training. Last year, we recorded it, and it had Professor John Muir, we had Dr. Susan Shares, special pediatric dentist, and we had ENT surgeon Dr. Perry Burson presenting. So once again, these are the prices, but specials do end 31st of May, about 10 days, whatever it is. Do check out all the different previous attendees, their words there. There's a full 30-day cancellation policy. If you book and something happens, you can cancel with a full refund. And also you can get a virtual ticket, which includes the recordings, and go through our material. If it's not what you're looking at, what you're expecting, get a full refund, right? So this is our kind of little thank you special for staying the full hour. Just simply email me. I'm head of enrollments, helping my brother out with all this, the business side of things. Ask me questions, anything you have questions related to the event, email me at info@straightteethnaturally tonight, anytime tonight, where you're dialing in from, and just put the subject header webinar special. We'll get additional 200 off. Okay, so you're getting basically the lowest prices we ever offered back in March, April. So, and we'll create a custom invoice for you, right? So you do need to email me tonight to get that extra $200 discount, and ask me the questions you need to ask, and we'll give you a few days to think about it and coordinate your schedule. Okay, we just recorded this after the webinar. We just realized a lot of you guys missed the live webinar. So what does it mean? So long as you send me an email, you've watched it all the way up to here, we're still going to honor the webinar special, right? So just email me at info@straightteethnaturally.com before the end of the month, all right? And to get this extra $200 discount off the current prices. Okay, so once again, email us, me specifically, at info@straightteethnaturally.com. Ask any questions you have about the program, about the event, and so long as you do so before the end of the month, we'll give you that extra $200 discount. All right, cheers.
There's so much more that I wanted to speak with you about, but I think your time is...
Well, let's see if we have some questions, would be great.
Yeah, so let's see if the audience wants to ask us any questions before you have to leave.
Yeah, I can definitely hang on another 10 minutes. That's fine.
Oh, wonderful.
Perfect. So there was a question. The first question that came in was from Dr. Silva. How is your orthotropics different from other orthotropics which only proclines in sizes?
That goes to, that's not mine.
Oh, sorry, that's Simon, sorry. So yeah, if you've got questions for Dr. Amanda, because she has to leave first in the next 10 minutes, please type it in the Q&A chat, please.
Yes. So what a lot of early intervention management is focused on mechanics. And mechanics can only move teeth. And when you're developing space and there's no space, you do end up tipping everything. Right? Teeth tip, because roots don't want to move because they're housed in bone, whereas the teeth are floating in the air. So when we are looking at mechanics, you get predominantly a tipping effect. But postural orthodontics is different because it incorporates the understanding of oral posture, the tongue pressure, the lip pressure, the cheek pressure. When you combine control of the tongue, control of the lips, control of the cheeks with the mechanics, then you get a double action. You get tipping through your appliance mechanics, but you get torque through tongue, lip, and cheek posture. And so you gain not only mechanics, but you improve the growth and development. Now, this can only happen in primary dentition and mixed dentition. It does not happen when puberty hits, which is why normally you see very poor outcomes in early intervention when doctors use early intervention techniques in teenagers. All right. You get the worst of all worlds when you use the wrong equipment and a lack of understanding to approach a problem that has already run away and grown up.
Sure.
Amanda, there's 3 questions there. Do you want to pick which one is relevant to you? Do you see all the questions from?
I do. Okay, so first one, I don't see the pano, so I probably can't answer that one. And
Okay.
whatever it was didn't attach. So maybe that's something that this doctor could bring to the course.
Oh, no,
If
that's
this doctor's coming.
directed at me.
Yeah.
Oh, okay, that's for you.
Maybe
Okay.
the third one from Dr. Kevin White. That's could be for you.
Sure. Does expansion, leveling the curve of Wilson, reducing the curve of speed, correct a deep bite, class 2, div 2? I think anytime you have here, I'll answer this live. Anytime you have a class 2, div 2 case, you obviously want to get your cephalometric x-ray and run your numbers to find out what your deep bite can be due to multi-factors. It could be fully related to a very low angle mandible, or it could be related to over extruded incisors, or it could be a combination of both. And you need to, without those cephalometric numbers, as well as the photos and everything, you're not going to know what kind of deep bite this is and how to treat it. So, like, for example, if I'm doing this case in Invisalign, I'm going to do some absolute intrusion of incisors if it's gummy, and some relative extrusion of molars and premolars. But you can do the same thing in appliances, because you can build ramps and stack acrylic in appliances. You can, if you're going to do braces, you can place the bracelets in a certain way to help intrude a little bit. So yeah, I mean, you can definitely fix a class 2 div 2 bite. It's a lot easier to do it when the child's younger than in a fully grown teenager.
Yeah, and of course, general rule of thumb for all orthodontics is there are a sequence of protocols. Level and align is the first step, and it means you've got to flatten the curve of Wilson and flatten the curve of Spey so that your mechanics is unimpeded by teeth being at different levels.
Yeah. And let me grab that last question as well, because that one's directed to me, and then I'm probably going to jump off and let Dr. Wong answer the other 2. But there was a question about appropriate rest posture and what I recommend: myofunctional therapy, myomunchies, myobrace. So I'll go ahead and answer that. To be honest, I am not trained in OMT. I've it's on my bucket list of things to do. I've gone through oral myofunctional therapy. It was a challenge. I was just wanted to make content about myofunctional therapy. So I was like, I found an oral myofunctional therapist. I went through the assessment just to see what it was like. And I recorded it all, right? And it turns out I was a hot mess. I actually had tongue thrusts, which I didn't even know I had. I had a massive tongue tie. And I think she was like, you can actually see all this stuff live, by the way, if you go to my YouTube channel, which is Straightsmile Solutions. I have over 2,000 videos on there, and type in the keyword OMT. You will see all this. It's actually, she was kind of like embarrassed because she felt bad telling me that I was really bad. I had terrible tongue posture and everything. And actually it affected my speech. If you listen to my old videos, like really old ones going back 5-6 years, I think you can hear a difference in my speech pattern, and I constantly have to correct myself. But in any case, I haven't been certified in oral myofunctional therapy. It's something I want to do. I don't think I have the patience to do it. I don't know that I had the right temperament. So I'm pretty familiar with it, but we refer, but I would like, if and when I go back into full-time practice again and have my own practice, I definitely plan on bringing in an in-house oral myofunctional therapist, because I think when you're constantly referring to a myofunctional therapist out, you tend to lose. You have a lot of attrition because they have to pay the supplemental fee. And I do work with a lot of doctors who have in-house oral myofunctional therapists. They just trained up either a dentist in their practice or their hygienist. And then they have a lot more treatment acceptance because they bundle it into the price of the ortho, and hopefully they're not assessing a ridiculous fee, and then they have almost 100% acceptance of treatment. And then their ortho treatments go way better, because if you have a habit, a massive habit, be it a tongue thrust, a tongue tie, or it might be SLP issues, and you just try to do the ortho without addressing that habit, the ortho's not going to go well. So, but I would love to hear Simon's answer to that too. And then I'm going to go ahead and jump off.
I was trained in my brace, trained with Chris Farrell about 20 years ago, actually. Did ALF, worked with osteopaths. And what I find is when there is a dysfunction, a specific dysfunction, a speech dysfunction, a thrust, I will refer to speech lingual pathology. But my program incorporates attention on improving posture. So if there's a dysfunction, I refer out. But if the posture is poor, I do it in-house. And the simple program that I developed, which is about 10 or 15 minutes every day of improving table manners and speaking manners, which should be a normal part of raising children everywhere around the world. That addresses the posture side of it. So, I will use when there's a specific speech issue or a functional issue with the tongue, then I'll refer out. That said, I tend not to refer anyone out until the structure is dealt with. So if there's a tongue tie, that has to be released first. If the jaws don't coordinate, I have to coordinate them. If the arch is too small, I have to make the arches bigger. Then we evaluate for dysfunction, because often the dysfunction is because there's just no room for anything.
Right. That's true. That's true. Yeah. Fascinating. That's what I'm looking forward to taking home from the course in September. So I'll be a student just like the rest of you as well.
And our guest speaker as well. Amanda, thank you so much for joining us tonight.
Thank you. Aloha.
Aloha.
I'm looking forward to watching the rest of the webinar, and I'll see a lot of you in September. Take care.
Take care. Thank you so much. All right,
bye, Amanda.
So on that note, I'm going to go back to questions, Simon.
And I've only got a minute or so because I've got to head off.
Yes.
Questions?
Quick questions from, let's go through the Q&A. Dr. Liu said, I'm a little lost conceptually about how you can conclude that mandibular expansion is possible from looking at an early mixed dentition pano, the pano with the vertical arrows.
Okay, so to clarify, mandibular expansion is not possible. It's physically not possible to expand the mandible. What is possible is mandibular arch expansion. So what that means is we can expand the dental alveolar bone. We cannot expand the basal mandible, but we can expand the dental alveolar bone. When you're looking at an early mixed dentition pano, the volume of dental alveolar bone is significant in a young mandible because of the number of teeth and teeth buds that are developing in the mandible. So the volume of dental alveolar bone being so great in an early mixed dentition means that if we engage that region, we can develop much broader arch forms. It doesn't affect the mandible basal bone, but we're not aiming to expand the mandible because it's not possible. We're only focusing on dental alveolar, but because the volume of dental alveolar is so high, we can get an enormous amount of change. And because they're so young, inadvertently, the dental alveolar bone influences the form of the basal bone. It has to.
All right, terrific. So there's also questions from Dr. Silva. I release if the palate is high to accommodate the newly freed tongue. Functional appliances are used in adults, though? Question mark.
I don't really treat anyone past actually the prepubertal period. So I don't have an answer for adults and functional appliances. I suspect, just through my own experiences, that it's very hit and miss when you're trying to do a functional approach with an adult, because functional appliances require some growth modification, and there's no growth possible in adults.
Okay, Dr. Adjan, what do you think of the ALF appliance in contrast to your appliances?
I again trained with Gavin and Stroken in Canada, and used ALF appliances for a very long time, and sometimes they work really, really well, but I found the outcomes to be unpredictable. And I don't like doing dentistry that's unpredictable. I like doing predictable dentistry. I'm certainly never going to teach anyone to do something that is unpredictable, because that makes it impossible for you to be successful. And my hope is for everyone who follows a system is that they're consistently successful with that system. So I found that I have developed a system that's consistently successful. So that's why I'm only teaching that particular system.
Terrific.
Okay, that's all I have time for.
All right, thank you, Simon. I know you have to head off to see patients. It's 12 o'clock in Melbourne, so thank you. And for those of you who'd like to meet Simon in person, do take advantage of our extra webinar special tonight to send me an email. Say thank you, Simon. Thank you, bro, so to speak. That's my older brother. I'll let you go first.
Maybe Enrico might show you his,
yeah. If you actually, Enrico, are you there? I don't know whether you got a few minutes.
Yeah, I'm here. Yeah, I'm here.
All right. Hello, Enrico. So Enrico has been working with Simon, talking about appliances for like 15 plus years, traveled the world with him, and really perfected the Wong widget. I don't know how else we call it. What do you call it, Enrico?
Tried, yeah.
Oh, yeah, all the different appliances, right? So
Yeah.
Yeah, look, it's if anyone has any questions for Enrico regarding that. Otherwise, let's see. I'm not a dentist, so I'm not going to be able to answer any other technical questions. But if you have any questions for Enrico, or any questions about the event in September, Enrico will be heading over as well. So, but thank you all for joining. If there's any other questions, I know it's getting late East Coast here, but I think there's some questions about finding doctors in Southwest Florida. That's a tricky, like, for what specifically, I don't think I can help you answer that question right here. Apologies. What age do you start functional appliances? These are all great questions. Once again, there's an opportunity to join our program now and get instant access to Simon's core training. And once you do that, you join our private Facebook group. And even before you fly over to New Jersey area, or even before you attend the virtual live stream, where you can plenty of Q&A time over the 2-day period, you can submit questions inside the closed Facebook group, if that helps. What labs, Dr. Silva said, I think this is relevant to you, Enrico. What labs in North America make these appliances of your brothers? Enrico, you want to answer that question?
Yeah, well, there's many labs, Kian, but as you know, I work for the States. I do work for about 26, 27 different states in America. And if that person is interested, I can give my email, lab@8pointortho.com.au. And we are in Canada. I'm seeing that he's in Canada, Dr. Simi. I work for about 7 or 8 different dentists in Canada. And we can, through DHL, I can get her the jobs back in 2 weeks, as like I always do for all 14 countries that I work for.
We recommend initially, if you are going to utilize Dr. Wong's protocols, to work with Enrico. And obviously, you know, because they've perfected the system, and you can obviously show the appliances to your local labs. And if, you know, they want to get trained up, Enrico can do that, and so on and so forth. But you know, it's a very precise science, and you know, just follow.
It has to be done a certain way. It is. Yeah. And
my understanding, it's literally taken that 15 years to kind of perfect.
Oh
so,
God, yeah,
absolutely.
Yeah. So
okay, so are there any lab techs besides yourself? I mean, you've got a whole company, right, Enrico?
I have. Well, I got about 14 staff.
Yeah. So
2
a lot of people,
and 12 technicians. Yeah.
Yes, a lot of students around the world are just ordering through Enrico initially.
Yeah.
On that note, unfortunately, we are all wrapped up for this evening. Apologies if we couldn't get through to everyone's questions. It was a packed event. So hopefully you'll join us in September. And whether you get a VIP or a virtual ticket, you can ask a lot of questions in our closed Facebook group. So once again, if you'd like to join us, I'll share once more that slide where you can take a picture of this. Let's see here. Here we go. So simply, if you want that extra webinar special, if you've made it until the end of tonight's presentation, additional $200 off the current early bird prices, you simply need to email me. You just need to email me tonight. You don't have to pay anything. You just simply say, I'd love to find out more. I'd like to take advantage of the webinar special if it makes sense. So email me at info. I'll personally reply, info@straightteethnaturally.com. Ask me any questions regarding the event. Yes, we have special room rates. There are discounts if you bring non-dental staff, etc., etc. So we will, you know, customize the invoice for your needs. All right. So once again, do send us an email, info@straightteethnaturally tonight. It has to be tonight to get the additional $200 discount. It's only for those who attended this live event tonight. So thank you, Enrico, for joining. Thank you, everyone.
Thank you, Keon. Thank you.
New Jersey area. And take care, Enrico. We'll see you in the next webinar.
See you soon.
All right.
Thank you, man.
Thank you, everyone, for joining tonight.